You're running down a hallway with your heart racing. Some unknown force is behind you, following your every step. No matter how hard you try, you cannot outrun it. Then it happens. You begin falling. The worst is yet to come. Can anything save you before you hit? Is the end near? The next thing you know, you wake up in bed covered in sweat. You've had a nightmare. But why? In this edition of Doc TV Monster Horror Documentary Series, we'll be headed to the scariest place imaginable. The human mind. It's time to shed light on nightmares. What is a nightmare? A nightmare, also known as a bad dream, is an unpleasant dream that can cause a strong emotional response from the mind, typically fear, but also despair, anxiety, or great sadness. However, psychological nomenclature differentiates between nightmares and bad dreams. Specifically, people remain asleep during bad dreams, whereas nightmares can awaken individuals. The dream may contain situations of discomfort, psychological or physical terror, or panic. After a nightmare, a person will often awaken in a state of distress and may be unable to return to sleep for a short time. Recurrent nightmares may require medical help, as they can interfere with sleeping patterns and cause insomnia. Nightmares can have physical causes, such as sleeping in an uncomfortable position or having a fever, or psychological causes, such as stress or anxiety. Eating before going to sleep, which triggers an increase in the body's metabolism and brain activity, can be a potential stimulus for nightmares. The prevalence of nightmares in children 5 to 12 years old is between 20 and 30%, and for adults is between 8 and 30%. In everyday language, the meaning of nightmare has extended as a metaphor for many bad things, such as a bad situation, a scary monster, or a person. Those with nightmares experience abnormal sleep architecture. The impact of having a nightmare during the night is very similar to that of insomnia. This is caused by frequent nocturnal awakenings and fear of falling asleep. Nightmare disorder symptoms include repeated awakenings from the significant sleep period or naps with a detailed recall of extended and extremely frightening dreams, usually involving threats to survival, security, or self-esteem. The awakenings generally occur during the second half of the sleep period. According to the International Classification of Sleep Disorders 3rd edition, or ICSD-3, the nightmare disorder, rapid eye movement sleep behavior disorder, also known as RBD, and recurrent isolated sleep paralysis form the rapid eye movement related parasomnias subcategory of the parasomnias cluster. Nightmares may be idiopathic without any signs of psychopathology or associated with disorders like stress, anxiety, substance abuse, psychiatric illness, or post-traumatic stress disorder. Greater than 80% of PTSD patients report nightmares. Regarding the dream content of the dreams, they usually imprint negative emotions like sadness, fear, or rage. According to the clinical studies, the content can include being chased, injury or death of others, falling, natural disasters or accidents. Typical dreams or recurrent dreams may also have some of these topics. What causes nightmares? Scientific research shows that nightmares may have many causes. In a study focusing on children, researchers concluded that nightmares directly correlate with the stress in children's lives. Children who experience the death of a family member or a close friend, or know someone with a chronic illness, have more frequent nightmares than those who are only faced with stress from school or social aspects of daily life. A study researching the causes of nightmares focuses on sleep apnea patients. The study was conducted to determine whether or not nightmares may be caused by sleep apnea or the inability to breathe. In the 19th century, authors believed that nightmares were caused by insufficient oxygen. Therefore, researchers thought that those with sleep apnea had more frequent nightmares than those without it. The results show that healthy people have more nightmares than sleep apnea patients. Another study supports the hypothesis. In this study, 48 patients aged 20 to 85 with obstructive airways disease, known as OAD for short, including 21 with and 27 without asthma, were compared with 149 sex and age-matched controls without respiratory disease. OAD subjects with asthma reported approximately 3 times as many nightmares as controls or OAD subjects without asthma. The evolutionary purpose of nightmares could be a mechanism to awaken a person in danger. Lucid dreaming advocate Stephen LaBerge has outlined a possible reason for how dreams are formulated and why nightmares occur. To LaBerge, a dream starts with an individual thought or scene, such as walking down a dimly lit street. Since dreams are not predetermined, the brain responds to the situation by either thinking a good or a bad thought, and the dream framework follows from there. If bad thoughts in a dream are more prominent than good ones, the dream may become a nightmare. There is a view, possibly featured in the story A Christmas Carol, that eating cheese before sleep can cause nightmares, but there is little scientific evidence for this. Severe nightmares are also likely to happen when a person suffers from a fever. These nightmares are often referred to as fever dreams. Can nightmares be treated? Sigmund Freud and Carl Jung believed that people frequently distressed by nightmares could be re-experiencing some stressful event from the past. Both perspectives on dreams suggest that therapy can relieve the nightmarish experience's dilemma. Direct nightmare interventions that combine compatible techniques from one or more of these classes may enhance overall treatment effectiveness. Analytic and cathartic techniques, storyline alteration procedures, face and conquer approaches, desensitization and related behavioral techniques. Recurring PTSD nightmares in which traumas are re-experienced respond well to a technique called imagery rehearsal. This involves dreamers coming up with alternative, mastery outcomes to the nightmares, mentally rehearsing those outcomes while awake, and then reminding themselves at bedtime that they wish these alternate outcomes should the nightmares recur. Researchers found that this technique reduces the occurrence of nightmares and insomnia, and improves other daytime PTSD symptoms. The most common variations of imagery rehearsal therapy, also known as IRT for short, relate to the number of sessions, duration of treatment, and the degree to which exposure therapy is included in the protocol. Can medication help with nightmares? Prazosin alfa, one blocker, appears helpful in decreasing the number of nightmares and the distress caused by them in people with PTSD. Risperidone atypical antipsychotic at a dosage of 2 mg per day has been shown in case series to remission of nightmares on the first night. Trazodone antidepressant has been shown in a case report to treat nightmares associated with a depressed patient. Trials have included hydrocortisone, gabapentin, paroxetine, tetrahydrocannabinol, esopicolone, Xyrem, and carvedilol. Does insomnia play a role in having nightmares? Insomnia is undoubtedly related to a more elevated chance of nightmares. Whether or not we dream or recall our dreams depends on how deep and relaxing our sleep is. Naturally, if you have insomnia, then you will be reasonably restless at what times of sleep you have. So, the critical difference is that insomnia doesn't directly cause nightmares. It's simply about how vividly we remember our dreams and how awake we are when they occur. Insomnia, also known as sleeplessness, is a sleep disorder in which people have trouble sleeping. They may have difficulty falling asleep or staying asleep as long as desired. Insomnia is typically followed by daytime sleepiness, low energy, irritability, and a depressed mood. It may result in an increased risk of motor vehicle collisions and problems focusing and learning. Insomnia can be short-term, lasting for days or weeks, or long-term, lasting more than a month. Insomnia can occur independently or as a result of another problem. Conditions that can result in insomnia include psychological stress, chronic pain, heart failure, hypothyroidism, heartburn, restless leg syndrome, menopause, certain medications, and drugs such as caffeine, nicotine, and alcohol. Other risk factors include working night shifts and sleep apnea. Diagnosis is based on sleep habits and an examination to look for underlying causes. Researchers may do a sleep study to look for underlying sleep disorders. Screening may be done with 2 questions. Do you experience difficulty sleeping? And do you have difficulty falling or staying asleep? Although their efficacy as first-line treatments is not unequivocally established, sleep hygiene and lifestyle changes are typically the first treatment for insomnia. Sleep hygiene includes a consistent bedtime, a quiet and dark room, exposure to sunlight during the day, regular exercise. Doctors may add cognitive behavioral therapy to this. While sleeping pills may help, they are sometimes associated with injuries, dementia, and addiction. These medications are not recommended for more than 4 or 5 weeks. The effectiveness and safety of alternative medicine are unclear. Between 10 and 30% of adults have insomnia at any given time, and up to half of the people have insomnia in a given year. About 6% of people have insomnia that is not due to another problem and lasts for more than a month. People over the age of 65 are affected more often than younger people. Females are more often affected than males. Descriptions of insomnia occur at least as far back as ancient Greece. Insomnia symptoms: difficulty falling asleep, including difficulty finding a comfortable sleeping position, waking during the night, being unable to return to sleep, and waking up early, not able to focus on daily tasks, difficulty in remembering, daytime sleepiness, irritability, depression or anxiety, feeling tired or having low energy during the day, trouble concentrating, being irritable, acting aggressive or impulsive. Sleep onset insomnia is difficulty falling asleep at the beginning of the night, often a symptom of anxiety disorders. Delayed sleep phase disorder can be misdiagnosed as insomnia, as sleep onset is delayed to much later than usual, while awakening spills over into daylight hours. It is common for patients who have difficulty falling asleep also to have nocturnal awakenings with problems returning to sleep. 2/3 of these patients wake up in the middle of the night, with more than half having trouble falling back to sleep after a middle-of-the-night awakening. Early morning awakening occurs earlier than desired, with an inability to go back to sleep and before total sleep time reaches 6.5 hours. Early morning awakening is often a characteristic of depression. Anxiety symptoms may well lead to insomnia. Some of these symptoms include tension, compulsive worrying about the future, feeling overstimulated, overanalyzing past events. Poor sleep quality can result from, for example, restless legs, sleep apnea, or major depression. Poor sleep quality is defined as the individual not reaching stage 3 or delta sleep with therapeutic properties. Major depression leads to alterations in the function of the hypothalamic pituitary adrenal axis, causing excessive release of cortisol, which can lead to poor sleep quality. Nocturnal polyuria and excessive nighttime urination can also result in a poor quality of sleep. Some cases are not insomnia in the traditional sense because people experiencing sleep state misperception often sleep for an average amount of time. The problem is that, despite sleeping for multiple hours each night and typically not experiencing significant daytime sleepiness or other symptoms of sleep loss, they do not feel like they have slept very much, if at all. Because their perception of their sleep is incomplete, they incorrectly believe it takes them an abnormally long time to fall asleep, and they underestimate how long they remain asleep. Sleep studies using polysomnography have suggested that people with sleep disruption have elevated nighttime levels of circulating cortisol and adrenocorticotropic hormone. They also have an elevated metabolic rate, which does not occur in people who do not have insomnia but whose sleep is intentionally disrupted during a sleep study. Studies of brain metabolism using positron emission tomography scans indicate that people with insomnia have higher metabolic rates at night and day. The question remains whether these changes are the causes or consequences of long-term insomnia. What is sleep paralysis? Sleep paralysis is a state during waking up or falling asleep in which a person is aware but unable to move or speak. During an episode, one may hallucinate, hear, feel, or see things that are not there, which often results in fear. Episodes generally last less than a couple of minutes. It may recur or occur as a single episode. The condition may occur in those otherwise healthy or those with narcolepsy, or it may run in families due to specific genetic changes. The condition can be triggered by sleep deprivation, psychological stress, or abnormal sleep cycles. The underlying mechanism is believed to involve a dysfunction in REM sleep. Lucid dreamers commonly experience sleep paralysis. Some lucid dreamers use this to have a lucid dream. Diagnosis is based on a person's description. Other conditions that can present similarly include narcolepsy, atomic seizure, and hypokalemic periodic paralysis. Treatment options for sleep paralysis have been poorly studied. It is recommended that people be reassured that the condition is common and generally not severe. Other efforts may include sleep hygiene, cognitive behavioral therapy, and antidepressants. Between 8 and 50% of people experience sleep paralysis at some point. About 5% of people have regular episodes. Males and females are affected equally. Sleep paralysis has been described throughout history. It is believed to have played a role in creating stories about alien abduction and other paranormal events. The main symptom of sleep paralysis is being unable to move or speak during awakening. Imagine sounds such as humming, hissing, static, zapping, and buzzing noises are reported during sleep paralysis. Other sounds such as voices, whispers, and roars are also experienced. It has also been known that one may feel pressure on their chest and intense pain in their head during an episode. These symptoms are usually accompanied by intense emotions such as fear and panic. People also have sensations of being dragged out of bed or flying, numbness, and feelings of electric tingles or vibrations running through their bodies. Sleep paralysis may include hypnagogic hallucinations, such as a supernatural creature suffocating or terrifying the individual, accompanied by a feeling of pressure on one's chest and difficulty breathing. The pathophysiology of sleep paralysis has not been concretely identified, although several theories about its cause exist. The first of these stems from the understanding that sleep paralysis is a parasomnia resulting from a dysfunctional overlap of the REM and waking stages of sleep. Polysomnographic studies found that individuals who experience sleep paralysis have shorter REM sleep latencies than usual, along with shortened NREM and REM sleep cycles and fragmentation of REM sleep. This study supports the observation that disturbance of regular sleeping patterns can precipitate an episode of sleep paralysis because fragmentation of REM sleep commonly occurs when sleep patterns are disrupted and has now been seen in combination with sleep paralysis. Another major theory is that the neural functions that regulate sleep are out of balance in such a way that causes different sleep states to overlap. In this case, cholinergic rest-on neural populations are hyperactivated, and the serotonergic sleep-off neural populations are underactivated. As a result, the cells capable of sending the signals that would allow for complete arousal from the sleep state, the serotonergic neural people, have difficulty overcoming the signals sent by the cells that keep the brain in the sleep state. During normal REM sleep, the threshold for a stimulus to cause arousal is significantly elevated. Under normal conditions, medial and vestibular nuclei, cortical, thalamic, and cerebellar centers coordinate things such as head and eye movement and orientation in space. In individuals reporting sleep paralysis, there is almost no blocking of exogenous stimuli, which means it is much easier for a trigger to arouse the individual. The vestibular nuclei, in particular, have been identified as closely related to dreaming during the REM stage of sleep. According to this hypothesis, vestibular motor disorientation, unlike hallucinations, arises from entirely endogenous sources of stimuli. If the effects of sleep on neural populations cannot be counteracted, Characteristics of REM sleep are retained upon awakening. Expected consequences of sleep paralysis include headaches, muscle pains, weakness, or paranoia. As the correlation with REM sleep suggests, the paralysis is incomplete. Use of EOG traces show that eye movement is still possible during such episodes. However, the individual experiencing sleep paralysis cannot speak. Research has found a genetic component in sleep paralysis. The characteristic fragmentation of REM sleep, hypnopompic and hypnagogic hallucinations have a heritable component in other parasomnias, which lends credence to the idea that sleep paralysis is also genetic. Twin studies have shown that if one twin of a monozygotic pair of identical twins experiences sleep paralysis, that other twin is very likely to experience it. The identification of a genetic component means that there is some sort of disruption of a function at the physiological level. Further studies must be conducted to determine whether there is a mistake in the signaling pathway for arousal as suggested by the first theory presented, or whether melatonin regulation or the neural populations have been disrupted. Several types of hallucinations have been linked to sleep paralysis. The belief that there is an intruder in the room, the presence of an incubus, and the sensation of floating. A neurological hypothesis is that in sleep paralysis, the mechanisms that usually coordinate body movement and provide information on body position become activated and induce a floating sensation because there is no actual movement. The intruder and incubus hallucinations highly correlate with one another. They are moderately associated with the third hallucination, vestibular motor disorientation, also known as out-of-body experiences, which differ from the other two in not involving the threat-activated vigilance system. A hypervigilant state created in the midbrain may further contribute to hallucinations. More specifically, the emergency response is activated in the brain when individuals wake up paralyzed and feel vulnerable to attack. This helplessness can intensify the effects of the threat response well above the level typical of ordinary dreams, which will explain why such visions during sleep paralysis are so vivid. The threat-activated vigilance system is a protective mechanism that differentiates between dangerous situations and determines whether the fear response is appropriate. The hypervigilance response can lead to the creation of endogenous stimuli that contribute to the perceived threat. A similar process may explain hallucinations, with slight variations, in which the subject perceives an evil presence attempting to suffocate them, either by pressing heavily on the chest or strangulating. A neurological explanation holds that this results from the threat vigilance activation system and the muscle paralysis associated with sleep paralysis that removes voluntary control of breathing. Several features of REM's breathing patterns exacerbate the feeling of suffocation. These include shallow rapid breathing, hypercapnia, and slight airway blockage, a symptom prevalent in sleep apnea patients. According to this account, the subjects attempt to breathe deeply and find themselves unable to do so, creating a sensation of resistance, which the threat-activated vigilance system interprets as a supernatural being sitting on their chest, threatening suffocation. The feeling of entrapment causes a feedback loop when the fear of suffocation increases due to continued helplessness, causing the subjects to struggle to end the SP episode. Sleep paralysis is mainly diagnosed via clinical interview and ruling out other potential sleep disorders that could account for the feelings of paralysis. Several measures are available to analyze or screen Munich parasomnia screening for recurrent isolated sleep paralysis. Episodes of sleep paralysis can happen in several medical conditions, such as narcolepsy and hypokalemia. When attacks occur independent of these conditions or substance use, it is termed isolated sleep paralysis, or ISP, when ISP episodes are more frequent and cause clinically significant distress or interference. It is classified as recurrent isolated sleep paralysis, or ISP. Episodes of sleep paralysis, regardless of classification, are generally short, 1 to 6 minutes, but longer episodes have been documented. It can be challenging to differentiate between cataplexy brought on by narcolepsy and true sleep paralysis because the two phenomena are physically indistinguishable. The best way to distinguish between the two is to note when the attacks occur most often. Narcolepsy attacks are more common when the individual is falling asleep. ISP and RISP attacks are more common upon awakening. Exploding head syndrome (EHS) is a potentially frightening parasomnia. The hallucinations are usually briefer, always loud or jarring, and there is no paralysis during EHS. Nightmare disorder (ND), also REM-based parasomnia. Sleep terrors STS potentially frightening parasomnia, but are not REM-based, and there is a lack of awareness of surroundings, characteristic screams during STS. Nocturnal panic attacks NP as involve fear and acute distress but lack paralysis and dream imagery. Post-traumatic stress disorder PTSD often includes scary imagery and anxiety, but is not limited to sleep-wake transitions. Can sleep paralysis be treated? Several circumstances have been identified associated with an increased risk of sleep paralysis. These include insomnia, sleep deprivation, an erratic sleep schedule, stress, and physical fatigue. It is also believed that there may be a genetic component in the development of RISP because there is a high concurrent incidence of sleep paralysis in monozygotic twins. Sleeping in the supine position is an exceptionally prominent instigator of sleep paralysis. Sleeping in the supine position is believed to make the sleeper more vulnerable to episodes of sleep paralysis because, in this position, the soft palate can collapse and obstruct the airway. This is possible regardless of whether the individual has been diagnosed with sleep apnea. There may also be a greater rate of microarousals while sleeping in the supine position because there is a more significant amount of pressure being exerted on the lungs by gravity. While many factors can increase the risk for ISP or RISP, they can be avoided with minor lifestyle changes. Medical treatment starts with education about sleep stages and the inability to move muscles during REM sleep. Doctors should evaluate people for narcolepsy if symptoms persist. The safest cure for sleep paralysis is for people to adopt healthier sleeping habits. However, tricyclic antidepressants or selective serotonin uptake inhibitors may be used in more severe cases. Even though these treatments are prescribed, there is currently no drug that has been found to interrupt episodes of sleep paralysis most of the time completely. Though no large trials have taken place which focus on treating sleep paralysis, several drugs have promise in case studies. 2 trials of GHB for people with narcolepsy demonstrated reductions in sleep paralysis episodes. Pimavanserin has been proposed as a possible candidate for future studies in treating sleep paralysis. Some of the earliest work in treating sleep paralysis was done using a cognitive behavior therapy called CACBT. The work focuses on psychoeducation and modifying catastrophic cognitions about the sleep paralysis attack. Although clinical trials are lacking, this approach has previously been used to treat sleep paralysis in Egypt. The first published psychosocial treatment for recurrent isolated sleep paralysis was cognitive behavior therapy for isolated sleep paralysis, CBT-ASP. It begins with self-monitoring of symptoms, cognitive restructuring of maladaptive thoughts relevant to ISP like the paralysis will be permanent, and psychoeducation about the nature of sleep paralysis. Prevention techniques include ISP-specific sleep hygiene and the preparatory use of various relaxation techniques such as diaphragmatic breathing, mindfulness, progressive muscle relaxation, and meditation. Episode disruption techniques are practiced in session and applied during actual attacks. No controlled trial of CBT-ASP has yet been conducted to prove its effectiveness. Sleep paralysis is experienced equally in males and females. Lifetime prevalence rates derived from 35 aggregated studies indicate that approximately 8% of the general population, 28% of students, and 32% of psychiatric patients experience at least one episode of sleep paralysis at some point in their lives. Rates of recurrent sleep paralysis are not as well known. Still, 15 to 45% of those with a lifetime history of sleep paralysis may meet the diagnostic criteria for recurrent isolated sleep paralysis. In surveys from Canada, China, England, Japan, and Nigeria, 20 to 60% of individuals reported having experienced sleep paralysis at least once in their lifetime. In general, non-whites appear to experience sleep paralysis at higher rates than whites, but the magnitude of the difference is relatively small. Approximately 36% of the general population that experiences isolated sleep paralysis is likely to develop it between 25 and 44 years of age. Isolated sleep paralysis is commonly seen in patients that have been diagnosed with narcolepsy. Approximately 30 to 50% of people that have been diagnosed with narcolepsy have experienced sleep paralysis as an auxiliary symptom. Most individuals who have experienced sleep paralysis have sporadic episodes that occur monthly to yearly. Only 3% of individuals experiencing sleep paralysis not associated with a neuromuscular disorder have nightly attacks. Samuel Johnson codified the original definition of sleep paralysis in his Dictionary of the English Language as a nightmare, a term that evolved into our modern meaning. The term was first used and dubbed by British neurologist S.A.K. Wilson in his 1928 dissertation, The Narcolepsies. Such sleep paralysis was widely considered the work of demons, and more specifically incubi, which were thought to sit on the chests of sleepers. Although the core features of sleep paralysis like atonia, a clear sensorium, and frequent hallucinations appear universal, how they are experienced varies according to time, place, and culture. Over 100 terms have been identified for these experiences. Some scientists have proposed sleep paralysis as an explanation for reports of paranormal and spiritual phenomena such as ghosts, alien visits, demons or demonic possession, alien abduction experiences, the night hag, and shadow people haunting. According to some scientists, culture may be a significant factor in shaping sleep paralysis. When sleep paralysis is interpreted through a particular cultural filter, it may take on greater salience. For example, if sleep paralysis is feared in a specific culture, this fear could lead to conditioned fear and thus worsen the experience, leading to higher rates. Consistent with this idea, high rates and long durations of immobility during sleep paralysis have been found in Egypt, where there are elaborate beliefs about sleep paralysis involving malevolent spirit-like creatures, the jinn. Research has found that sleep paralysis is associated with great fear and impending death in 50% of sufferers in Egypt. A study comparing rates and characteristics of sleep paralysis in Egypt and Denmark found that the phenomenon is 3 times more common in Egypt versus Denmark. Unlike Egypt, Denmark has no elaborate supernatural beliefs about sleep paralysis. The experience is often interpreted as an odd physiological event, with shorter sleep paralysis episodes and fewer people, 17% fearing that they could die from it. Sleep disorders in folklore. The night hag is a generic name for a folkloric creature found in cultures around the world and used to explain the phenomenon of sleep paralysis. A standard description is that a person feels a presence of a supernatural evil being that immobilizes the person as if standing on the chest. This phenomenon goes by many names. Cambodia. Sleep paralysis among Cambodians is known as the ghost pushes you down, and entails believing in dangerous visitations from deceased relatives. Egypt. In Egypt, sleep paralysis is conceptualized as a terrifying jinn attack. The jinn may even kill its victims. Italy. In the different regions of Italy, there are many examples of supernatural beings associated with sleep paralysis. In the areas of Marche and Abruzzo, it is referred to as a pandafich attack. The pandafich usually refers to an evil witch, sometimes a ghost-like spirit or a terrifying cat-like creature, that mounts on the chest of the victim and tries to harm him. The only way to avoid her is to keep a bag of sand or beans close to the bed so that the witch will stop to count how many beans or sand grains are inside it. A similar tradition is present in Sardinian folklore, where the Amantador is known as a creature that mounts on the people's chest during their sleep to give them nightmares, and that can change its shape according to the person's fears. In northern Italy, specifically in the Tyrol area, the trout is a witch that sits on the people's chests at night, making them unable to breathe. To chase her away, people should make the sign of the cross, something that would need a great struggle in a situation of paralysis. Similar folklore is present in the Sannio area, around the city of Benevento, where the witch is called Gennara. In southern Italy, sleep paralysis is usually explained by the presence of a sprite standing on the people's chest. If the person manages to catch the spirit or steal his hat in exchange for his freedom or to have his hat back, he can reveal the hiding place of a rich treasure. This sprite has different names in different regions of Italy. Moniciello in Campania, Monicicchio in Basilicata, Lori di Hue or Scazzamural in Apulia, Masnured in Molise. Newfoundland. In Newfoundland, sleep paralysis is referred to as the old hag, and victims of a hagging are said to be hag-ridden upon awakening. Victims report being wholly conscious but unable to speak or move, and report a person or animal sitting on their chest. Despite the name, the attacker can be either male or female. Some suggested cures or preventions for the old hag include sleeping with a Bible under the pillow, calling the sleeper's name backward, or in an extreme example, sleeping with a shingle or board embedded with nails strapped to the chest. This object was called a hag board. The old hag is well known in the province as a pop culture figure, appearing in films and plays as well as in crafted objects. Nigeria. Nigeria has a myriad interpretations of the cause of SP. This is due to the very diversified culture and belief system that exists there. United States. Sleep paralysis is sometimes interpreted as space alien abduction in the United States. Literature. In literature, various forms of magic and spiritual possession were also advanced as causes. In 19th century Europe, the vagaries of diet were thought to be responsible. For example, in Charles Dickens's A Christmas Carol, Ebenezer Scrooge attributes the ghost he sees to an undigested bit of beef, a blot of mustard, a crumb of cheese, a fragment of an underdone potato. In a similar vein, the Household Cyclopedia 1881 offers the following advice about nightmares. Great attention is to be paid to regularity and choice of diet. Intemperance of every kind is hurtful, but nothing is more productive of this disease than drinking bad wine. Of eatables, those which are most prejudicial are all fat and greasy meats and pastry. Moderate exercise contributes in a superior degree to promote the digestion of food and prevent flatulence. Those, however, who are necessarily confined to a sedentary occupation should particularly avoid applying themselves to study or bodily labor immediately after eating. Going to bed before the usual hour is a frequent cause of nightmares, as it either occasions the patient to sleep too long or to lie long awake in the night. Passing a whole night or part of a night without rest likewise gives birth to the disease, as it occasions the patient on the succeeding night to sleep too soundly. Indulging in sleep too late in the morning is an almost certain method to bring on the paroxysm, and the more frequently it returns, the greater strength it acquires. The propensity to sleep at this time is almost irresistible. J. M. Barrie, the author of the Peter Pan stories, may have had sleep paralysis. He said of himself, "In my early boyhood, it was a sheet that tried to choke me in the night." He also described several incidents in the Peter Pan stories that indicate that he was familiar with an awareness of a loss of muscle tone while in a dream-like state. For example, Mamie is asleep but calls out, "What was that? It is coming nearer. It is feeling your bed with its horns. It is boring for into you." When the darling children were dreaming of flying, Barrie says, "Nothing horrid was visible in the air, yet their progress had become slow and labored, exactly as if they were pushing their way through hostile forces. Sometimes they hung in the air until Peter had beaten on it with his fists. Barry describes many parasomnias and neurological symptoms in his books and uses them to explore the nature of consciousness from an experiential point of view. Like all subjects in this series, nightmares will continue to horrify and fascinate the public. Why they happen, what causes them, and how we deal with them depends on the individual. Join us for another episode of Doc TV's monster horror documentary series soon.